Right, hello everybody. We're just letting people in. So I'm Martin Knapp. I'm going to chair the webinar today. I think we will get started now. So I'm delighted that we've got this webinar happening today. We've been hoping to have this for a little while and it's been difficult to arrange with other things going on. So we have Kathryn Skivington and Kathleen and Boyd, both from University of Glasgow, who are going to be presenting today. This is an NIHR, National Institute for Health and Care Research, School for Social Care Research webinar. And the plan is that Kathryn will start and then there'll be an opportunity for some questions immediately after her presentation. Then we'll hand over to Kathleen and again, opportunity for some questions. And then there'll be time, I'm sure, later on for more general discussion. So what I'm going to say to you is if you've got questions you want to, or points you want to make, either bung them into the chat or you can just put it into the chat. I'd like to ask a question or whatever, just something so I know and I can identify you. And we should have plenty of time for very specific and more general discussion. So I'm going to hand over to Kathryn. And then hopefully I will disappear from the screen, but we'll see what happens with this setting. So Kathryn, over to you. Thank you very much.
Great, thank you, Martin, and thanks very much for having us here today to present to you. So Kathleen and I are going to provide some detail on our framework that was published last year on developing and evaluating complex interventions. I'm going to give a little overview of where the framework came from and why we set about doing this update, and then go into kind of a bit more detail on these motivations and the key changes that were made from the previous version. So just to start, for those of you who are unfamiliar or need a refresher on where the framework came from, it was originally an MRC framework for the design and evaluation of complex interventions to improve health. It was really to try to provide guidance on rigorous methods for evaluating the effectiveness of non-pharmacological interventions. It talked largely about complex interventions as those made up of various interconnecting parts, and in terms of evaluation, largely focused on effectiveness and particularly randomized control trials. The framework was then updated in 2006 with an accompanying BMJ paper published in 2008, which was much less linear and more flexible than the version published in 2000. It took into account different types of interventions, so not just those developed by researchers, but also policies and other non-researcher-led interventions. Did move a little bit away from just thinking about effectiveness, but largely that was largely the focus in terms of evaluation. So the current version was something that we as a team set about doing a good few years ago now, for various reasons, but largely to update on methodological and theoretical developments since the 2008 paper was published. So there's various debates and discussion about the guidance included in the 2008 version, which we've tried to address somewhat, although obviously addressing every criticism can be quite tricky. Another thing to, just before I move on, just to make sure that we're all on the same page about what an intervention is. So when we're talking about an intervention, we're talking about an action or program that aims to bring about identifiable outcomes. So it's a really broad term. We're thinking about everything from medical treatments, it could be like a surgical intervention, to changes in policy. So perhaps a change in welfare policy could be developed and implemented by the research team, or it could be something beyond the researcher's control. And our focus was particularly on interventions that are likely to have an impact on health. So there are various reasons that we took on this update related to the methodological and theoretical developments that I mentioned already. Excuse me. I'm not going to read out all of these just now because I'm going to go, this is how I'm going to structure the next 20 minutes or so. I'm going to talk about these things that prompted our update and what we did about them as well. I just also wanted to highlight how well cited the intervention guidance was. So the 2008 BMJ paper has been cited a lot of times over the last decade or so. I think at last check it was cited over 10,000 times. So it was clearly being used a lot in funding applications and in research publications. So it was really important, I think, to make sure that the developments that had occurred in the field since then were represented in this document, which is very well used. I'm not going to go into any detail really on how we went about the update, other than just to say there are lots of details in the NIHR Journals Library publication if you want more information on that. But just to really highlight that we went through a fairly lengthy process of consulting the literature as well as expert advisors and open consultation, and we got really a lot of feedback from that and from the various rounds of peer review. So the version that we worked on was published last September, like I said, in the BMJ and the NIHR Journals Library for a longer version of the monograph. Okay, so now I'm going to go into a bit more detail on the key parts of the update. So one reason we wanted to update it was to update the definition of complex interventions, particularly highlighting the relationship between the intervention and its context. This was a previous definition of complex intervention from our colleague Peter Craig's version of the guidance in 2006 or 8, depending on which version you're reading. So it talked about the number of and interactions between components within the experimental and control interventions, the behaviours required by those delivering or receiving the intervention, the number of groups or levels targeted by the intervention, for example, patients, service providers, hospitals, etc. The number and variability of outcomes that were targeted, and the degree of flexibility or tailoring of the intervention that was permitted. We would say that these things are all important and likely make an intervention complex. But we wanted to emphasize that the characteristics of the intervention itself are complex, but also the interactions between the intervention and its context lead to complexity as well and are important to recognise. So when I'm talking about context, I'm talking about any features of the circumstances in which an intervention is conceived, developed, evaluated and implemented. Effects of interventions can be highly context dependent, and when I'm talking about context, I'm thinking about dynamic and multidimensional context. Examples could be political context, economic context, etc. So one example is this picture on the right, the lucky iron fish, which is a small iron ingot, and it's placed in cooking pots as a way of preventing dietary anemia. A bit of the iron from the fish leaches into the cooking water, and the idea is that it can reduce dietary iron deficiency. So under the previous definition of complex interventions, this would come across as relatively simple. It's got no moving parts. It doesn't seem to require any complex behaviours. But if you actually think about the whole process of manufacturing and supplying the fish, encouraging people to use them, plus the local contextual factors that could interact with how the intervention works, it does become fairly complex. So this is a very straightforward logic model. So the problem is endemic dietary iron deficiency. The intervention was originally designed for rural Cambodians where this was identified as a problem. The iron fish could be produced and sourced locally, and the fish shape was actually used to increase uptake because fish are widely considered to be lucky in Cambodian villages. So the idea that that would increase iron intake and that anemia would be reduced. So various aspects of the context would make it likely that the intervention would work. And although some trials have shown that the fish have been effective in reducing iron deficiency anemia, other trials have actually shown no effect. And that's been later found to be because anemia in these regions is actually due to inherited problems related to hemoglobin production, rather than necessarily iron deficiency. So it's just really to highlight that the effectiveness of an intervention depends on various aspects of the context. I've got some ideas here of the things that may influence the intervention's effectiveness in this context. And I think that just highlights that no intervention is in fact truly simple, and there's a great deal of skill and judgment involved in deciding which dimensions of complexity are important. And that's what the new framework tries to emphasize, this sort of complexity. So the second motivation was to shift the focus to the usefulness of evidence as the basis for determining research perspective and questions. So these are the previous versions of the guidance and how they set out the framework. So the 2000 version of the framework really arose through a translation of the types of framework that were used to guide drug development research, and it was adapted to be fit for evaluating more complex interventions in public health and health care. But it largely remains within a paradigm where the cardinal question was, does it work? Does the intervention work? So in terms of evaluation, it's focused largely on unbiased estimates of effect. You can see the fourth phase here is definitive randomized controlled trial. So that's a necessary step in the process towards long-term implementation. In 2006, there's obviously a much less linear framework, and it does move beyond researcher-developed interventions to talk about natural experiments as well, although it does so in a limited way, I would say. And in terms of evaluation, there is definitely, in that document, there was definitely mention of understanding the change process, or thinking about process evaluation, but it was largely still focused on assessing effectiveness. The problem is that many of the most promising interventions don't get or can't be evaluated in this way. So if we think about service and policy innovation or population level policies, often these things are not suitable for a randomized controlled trial, for example. And even if they are effective in a controlled trial, it's not always replicated when the intervention is implemented in the real world. So there's various reasons for why an intervention effect might not be replicated from a trial to real world. It might be that it's not implementable, or it encounters implementation failure. It's not transferable across contexts, or even if it's shown to be effective in the short term, then it's implemented, the effects might be washed away or diluted because of systems change. And I think that's particularly evident in interventions that are tackling so-called wicked issues like obesity, where the system of influence is huge and where a small change in one aspect of the system is unlikely to make much of a difference in the long run. But I think that this is an issue in contexts more broadly than just these big sort of population level interventions. So I think it's worth us thinking about what that means for our intervention research, regardless of the size of the intervention or the problem. So this has arguably led to a production line of researcher-led effective interventions, inverted commas, that are limited in terms of the implementation requirements and stakeholder insights, and generally don't work. So this is a quote from Doug Altman, who advocated for change in methods and reporting of intervention research, or research more generally. He stated that we need less research, better research, and research done for the right reasons. So one way that we thought about promoting this in our framework document was to emphasize the use of diverse research perspectives. So in the document, we've highlighted 4 different research perspectives, from efficacy perspective through to a systems perspective. I'm going to take each of these in turn and give some more details. So I won't read out this slide, but a key point to note about this is that we were really wanting the framework to be flexible and take a pluralist approach. So we wouldn't suggest that you have to choose one research perspective and stick to that, but that they can be combined in some way depending on the research question. So the research perspectives we postulate should guide the design and the conduct of the complex intervention research. And what we aim to do with this is to encourage awareness, understanding, and use of research that gives sufficient and appropriate consideration to different sources of complexity. So we think about an efficacy perspective. This is an exploratory approach to test causal hypotheses about the outcomes generated by the intervention. In an efficacy perspective, the aim is for high internal validity and controlling of contextual variation. So really thinking about how the intervention works in idealized conditions. So an example in a sort of non-drug trial study would be an intervention delivered in primary care where nurse practitioners receive intensive training to deliver the states of behavioural intervention to individuals who have identified themselves as being motivated to engage. So we've got highly trained practitioners and motivated patients within volunteer GP practices, say. If we move on to an effectiveness perspective, this is similar to efficacy, but here the aim is to test an intervention in samples and settings representative of those in which the intervention would be implemented in practice. Still interested in average estimates of effect, but here there's some intervention flexibility. And this is quite similar to an efficacy perspective. So it's still about testing causal hypotheses and about exploring the outcomes that are generated by the intervention. But here it's tested in a kind of real world setting, if you like. So following on from the example that I gave for efficacy, if we think about the same behavioural intervention delivered by nurse practitioners, we might think about a random sample of primary care centres in a local authority to patients who are referred by GPs rather than necessarily volunteer patients. Sorry, my slides are moving on by themselves. And perhaps not as highly trained nurses. So thinking about a theory-based perspective, there's a family of theory-based evaluation approaches, and they come from different disciplines, so social sciences, health sciences, international development. And they seek to identify the underlying theory or mechanism of an intervention, thinking about what's beneath the surface. They are still, I would say, underpinned by causation, thinking about why things work the way they do. So causation is certainly at the heart of most of these approaches. And program theory is one of the consistent threads, or theory of change, one of the consistent threads through the theory-based approaches. So we're looking at causal connections between activities and outcomes, either intended or unintended, and theorizing these links and trying to explain them. Just a note on program theory. So there's various different terminology for a bunch of things, or maybe one thing that's that are quite similar. So think about logic models, theory of change, program theory. And we differentiated a bit from what each of these terms mean, and we mostly talk about program theory in our document. So we're talking about program theory as describing how an intervention is expected to lead to its effects and under what conditions. It articulates the key components of the intervention, the mechanisms of the intervention, the features of the context, and how the mechanisms might influence context. We think about a logic model as a visual representation of a program theory rather than the program theory itself. So we'd always encourage people to articulate the program theory in text and then possibly simplify it in a visualization, for example, a logic model, to disseminate or communicate with stakeholders, etc. Okay, moving on to a systems perspective. So a system is a set of things. So for example, cells, people, organizations that are interconnected in such a way that they produce their own pattern of behavior over time. Systems thinking can help us to understand the interaction between the intervention and the context in which it is implemented in a dynamic way. So what I think it encourages us to think much more about the bigger picture and where the intervention is situated and how interventions can impact on different parts of the system, sometimes in unexpected ways, through various systems properties, which I'll come to in a second. So outcomes emerge from the interaction of the parts of a system in ways that cannot necessarily be predicted from the properties of the individual parts. So we're suggesting that a system can't be understood by breaking it down to its individual entities and studying each part separately because they're so intrinsically linked. And we can think about theorizing interventions as events and systems. That was something that was put forward by, I think it was by Penny Haw over a decade ago. And that's something that we've really tried to develop in our writing. So these are some examples of system properties that help explain why we can't think of complex interventions as discrete entities. I don't have time to go into any detail on each of these, but there is much more information in our BMJ paper on all of them. Just to give one example, adaptation is how the system responds to change. So we can think about asking, does an intervention or event prompt people to do things differently? And does that lead to other changes in the system? An example of that is the sugar sweetened industry levy, which is a tax based on the amount of sugar that's in drinks. And what happened was the system adapted, industry reformulated their products to include less sugar to avoid the tax. So that's an example of adaptation. So there's been lots of talk about systems perspectives, and as Harry Rutter and colleagues wrote in 2017, rhetoric urging complex systems approaches is only rarely operationalized in ways that generate relevant evidence or effective policies. And I think that is changing, but largely possibly still the case. But I think with our framework and our discussion of taking a systems perspective forward, that can encourage researchers to develop research questions that take into account these wider contextual factors that influence an intervention, and hopefully encourage researchers, funders, practitioners, and policymakers to develop, evaluate, and implement systems interventions. In terms of methods, I think we've got some way to go, or at least some way to go in providing good examples in health, or bringing these examples together. But there are definitely some good examples out there. I think that systems perspectives can also change the focus of intervention. So thinking, rather than targeting individuals with interventions to bring about behaviour change, we might think now about upstream action to create the conditions, context, relationships, etc., that support such behaviour change. We might move from thinking about one-off brief interventions to systemic sustained change in whichever organisation that you're working in, whether it's social care setting, school, workplace, policy, etc. It can also help to change the focus of the evaluation from thinking about what works to actually what contributes to the system in a positive way. So we're thinking about, rather than attribution, thinking about contribution. And actually, so the sort of questions that we might ask are, how will the research make a difference? Who will use it and who will benefit from it, in order to guide our research design. This doesn't necessarily have to take use systems methods, although it could do, but could also draw on a theory-based approach. And like I said before, the research perspectives that we've highlighted are not mutually exclusive. So in saying this, I'm not saying don't do randomized control trials, and I hope that that's not the message that you're getting from me just now, but rather, if a randomized control trial is appropriate, then to do it in combination with thinking at least about a systems perspective or a theory-based perspective. So yeah, I think I've already said this. Really, it's important to consider the sources of complexity surrounding an intervention before deciding on that research perspective. And then that will, in turn, lead to the development of research questions. So we're thinking about what is already known, what is the most important thing to find out. And for many interventions, the most pressing research questions won't necessarily be addressed by research that's restricted to questions of efficacy and effectiveness. Okay, so to move on to the final motivations that I was going to discuss today, we wanted to give due attention to intervention adaptation and to interventions developed outside of the research teams. And we also wanted to highlight various important aspects of complex intervention research that are not necessarily always given due focus. So this is the framework that we came up with after various iterations and discussions across, well, over a few years. So to give due attention to intervention adaptation and interventions developed outside of the research team, what we did was expanded the box on the left and within the dotted lines. So rather than it just being about developing an intervention, we've added to identify an intervention. So choosing an intervention that already exists, for example, via policy or practice, and exploring its options for evaluation. And we talk a lot about evaluability assessment in our frameworks. Really encourage that as an approach to designing an evaluation, particularly for these identified interventions, but I think can also be useful for developed interventions, or at least aspects of evaluability assessment can be useful for developing interventions as well. So evaluability assessment is about planning an evaluation. It's really important in getting stakeholders together to do this. So that would be part of the process of the evaluability assessment, to gather together stakeholders and work out the program theory. So for example, if it's a policy that's already been implemented, there might not necessarily be a version of a program theory, but talking to stakeholders to work out how the policy came about and what it was expected to achieve and how can help to guide the evaluation. And as part of the evaluability assessment, the research team would also do a sort of search for available data that could inform an evaluation, and then come up with a range of evaluation options. There's various writing on evaluability assessment linked within our document if you're interested in finding out more. In terms of feasibility, I don't think we've changed that phase very much, but we've added a bit more detail in the document. And I've already highlighted the changes to evaluation. Really, we want to think about assessing an intervention by using the most appropriate methods to address the research questions posed. Another kind of key update in this version is that we've really highlighted the importance of implementation throughout the research process. So although we've got it as a separate box here, we've definitely fed it into each of the other phases. I think that's probably fairly obvious why. If we develop an intervention that is ultimately not implementable, then it seems to be rather pointless to develop the intervention in the first place. It's really, really important to have an eye towards implementation from the very start. And then the other thing we wanted to highlight was these, what I mentioned before, various aspects of complex intervention research that are not necessarily given due focus. Excuse me. So there we've got the core elements in the middle, and we suggest that research teams should kind of revisit these core elements throughout the research process, and particularly between phases of research. So context I've already talked about quite a bit. The importance of developing, refining and retesting program theory. Again, I've mentioned that. Just to highlight as well that the refined program theory is an important evaluation outcome in itself. So it's great when research teams present how their program theory has evolved, if you like, and have a refined program theory at the evaluation phase. Engaging stakeholders and meaningful engagement of stakeholders is really key to all of this. That can obviously be tricky at times, but very important step. I think identifying the key uncertainties, again, I've talked a bit about this already. It's largely about finding out thinking about why we're doing the research in the first place, who it's important for, who's going to benefit from it, and what people actually want to know. We added intervention refinement. So there's the process of fine-tuning an intervention as you go. This element really depends on which perspective you're taking. So for example, if you're taking an efficacy perspective, then there might not be very much refinement of the intervention at that evaluation phase. Whereas if you're taking a theory-based or a systems perspective, then there might be more flexibility in the intervention. And economic considerations, that was one of the key motivations for the update as well. And I'm actually not going to say anything at all about that because Kathleen's going to follow on with a presentation largely around the importance of economic considerations. So that's all I was going to say about the framework. Just before I finish, I'd like to acknowledge my co-authors and some other colleagues and everyone who's involved in the getting the framework to where it is now and published. So thanks very much for listening.
Thanks enormously, Kathryn. That was a wealth of material. It's wonderful. Thank you. Right, as I said earlier, we've got time for some quick comments or questions now. A few minutes if people want to come in with any thoughts. So either put your hand up electronically, I can't see you on screen otherwise, or put something in the chat. Just put your name in the chat and I'll come to you. So any questions? Okay, so Andrew B.
Thanks, Kathryn. Excellent presentation, and I really like this framework. It's had a lot of thought behind it. But one of the things that I wonder is an issue with it is almost the assumption sometimes that context is a single entity, if you like, and very often context is to do with the perspective of evaluation that you're taking. So, for example, with having to pay for parking with hospital car parks, there's the perspective from the patients, there's the hospital perspective, there's the health service perspective, there's the social perspective. So I just wondered whether you had the opportunity within your framework to tease out the fact that context is relative rather than just being a sort of fixed socio-economic configuration.
Yeah, thank you. I think that's a really good point. And yeah, I was a bit conscious when I say there is a social context and an economic context, because you're totally correct, in saying that there are different perspectives to such context. We might all view them differently. I think that's where we highlight the importance of engaging with stakeholders, and there's various methods that you can use, I'm sure you're familiar with, to sort of explore multiple perspectives on these things. And more now, I think in our research that we're doing, we're drawing on soft systems methodology to bring people together to explore these different perspectives and try and make some sense of how they view problems in a different way and how they view interventions in a different way. But I'm not sure that I've got when you say if we managed to tease it out, I'm not sure that we have completely managed, but I think it's something that is definitely in our minds and we're progressing, and it would be great to hear from anyone else who's working in thinking about these things and how you have tackled this issue.
Thank you. Open for other comments. I'm just going to jump in with a comment myself. So following on from that last point from Andrew, I mean, we often say in social care research that there's much more local variability that you see than you perhaps see in the health context. In England, you have 150 plus local authorities with lots of different systems, and that then emphasises the importance of getting. I mean, I think personally, I really like the emphasis you've given today and in the document on context and making sure that's there. But that then makes the research in the social care context even more complicated to take that into account. And I'm just wondering, whether you think funding bodies, commissioning panels are ready for the more expensive research projects that probably would result if we are to take proper account of context.
So on our author group and advisory group, we had representation from various funders, NIHR and MRC largely, and we had some experts representing other funders as well. So I think, yes, that they're engaged in this conversation, so in the document as well, we include a checklist which we had kind of hoped would be used, that funders might use to explore whether these things had been addressed in proposals. But yeah, I think it's really tricky because, yeah, you're right, they're going to be expensive proposals, and I think somewhat iterative. Sometimes, if we're talking about taking the systems perspective based on a problem, then maybe if we're thinking about intervention development, we can't necessarily define what the intervention is right at the start before we've done all this exploratory work, which is, if we want meaningful engagement with people, then it comes at a price. I hope that this framework is one step in the right direction for that to be taken on board more so by funders, and I've received good feedback so far, but I mean, I don't sit on any funding panels, so I'm not sure.
You will soon, but I mean, just a quick follow-up that I'll go to Kathryn. I mean, which is, I think the checklist is a really good point. So I think in areas where checklists have been developed, through Cochrane, through health economics evaluations and so on, I think they often provide a sort of framework for authors or for applicants' research to use, because they know that the journal or the reviewing panel is going to use something similar as well. And as long as those checklists are valid and appropriate, at least it helps with a degree of consistency and predictability to the review process. So that might be quite helpful. Anyway, that was a bit of a wandering comment. Let me go to Kathryn, then to Juliet, and then after that we'll go on to Kathleen's presentation. So Kathryn first.
Thanks. Yeah, really useful presentation. We're doing a project on taking systems seriously in social care, so it fits really well with that. And I guess, I mean, Martin's highlighted problems that funders might have with this approach. My concern would perhaps be more about people working in practice, that the sort of the difficulty of doing anything once you've recognized, once you've sort of swallowed the pill of recognizing that everything is a complex system, I think runs the risk of encouraging sort of fatalism or a kind of sense of being a bit frozen as a practitioner or a local authority commissioner or whatever. So I guess, have you thought about anything from how the world looks from their perspective and how we can actually sort of turn this into something which is useful rather than just overwhelming?
Yeah, I think you're right. Everybody remembers that obesity foresight diagram, and that is a possibility for putting people off, because it was so massive, and if there's so many problems, then where do you begin? And I'm only one person, and what can I do? I think, but I kind of think that we need to recognize that everything's interconnected in that way. But another step is to create a boundary for what it is that we're actually studying. So, and that then somewhat involves also discussing with stakeholders which aspect of the system we can kind of meaningfully engage in, which one where we're going to concentrate our efforts, and whether that will have a reasonable level of change in the right direction. I don't think I have actually considered, from the point of view of practitioners, etc., what what they would think about that. So sorry, I don't really have a great answer for that question, but a very good food for thought. Thank you.
Good, we like food for thought. Juliet.
Hi, yeah, it's just a really quick question, I suppose. So, I mean, one of the things that I found really useful about the previous guidance, and I think is useful about this guidance as well, is the examples. But one area where there's not that many examples is in the systems, the evaluations that have taken a systems perspective. And I mean, that probably is because not so many people have done that, and it is very much an emerging field. But I just wonder if there's any possibility of kind of adding to it or finding some way to bring those examples in a more sort of fluid way as we move forward, because it just would be really useful to have kind of more examples of how people have dealt with this in the evaluation context.
Yeah, totally agree. Thank you very much. We were talking about that a lot over the course of the development of the work, and we're kind of debating whether we should write as much about the systems perspective because we don't have such good examples, or there are examples in other fields, but I'm not sure if they've been translated so much into health, and I'm sure we've missed out a load as well. So yeah, there's definitely space for that. And one idea that we have currently is to update the guidance on a more fluid basis, like you say, so try and keep a living document, but that's at a kind of early stage of discussion. So if we can get the funding and resource to do that, then that would be great. And again, also welcome any ideas or suggestions for kind of case study examples for that.
Okay, thank you very much, Kathryn, and for those questions. So as I said earlier, there'll be time to come back with more questions later on for Kathryn, if you want to, or generally. But I'm going to hand over now to Kathleen, who's going to pick up on the economics part. So over to you, Kathleen.
Thank you. I'm just in the process of sharing my screen. Oops, maximize it.
Yep, that's good.
Is that still?
Yes, we can see.
Fabulous. Okay, thank you, and thanks, Kathryn, for introducing the guidance. So yeah, so I'm going to concentrate on the economic considerations of the guidance. And so what I thought I would do is focus just on a little bit of overview of what the economic analyses in terms of complex interventions, what the guidance says, and then focus on the kind of key elements, basically focusing on those 4 phases that Kathryn talked about and how those key economic considerations can be what's most relevant in those 4 different phases. And then I'll talk a little bit about the implications and considerations for using the guidance in practice. And I've added a couple of slides on a kind of case study that's not actually in the guidance context, but is a recent project that I've been working on, which is funded by NIHR, and I think it's really good kind of context about how we can try and put some of what we're seeing into practice. So just to start off, I thought and now Kathryn has already been through what the kind of limitations of the previous guidance and what the purpose was for doing this, and I'm not wanting to reiterate that, but what I did want to focus on was one of the key problems related to economics, which was the lack of detail on economic evaluation. And in the guidance, what the aspects related to economic evaluation in the previous guidance was mostly focused on pre-trial modelling, so including pre-trial economic evaluation prior to a full evaluation. And this can help identify weaknesses, tell you if it's likely to be cost effective or not, and maybe identify areas of uncertainty, which is absolutely true. It can do that. But I think what the previous guidance didn't really do was think about all the other things that economic considerations can do for you, which is a lot more. And specifically, and I'm going to talk a lot about this as we go through in the feasibility and pilot stage. There was the previous guidance, and the current one talks a lot about process evaluation, testing acceptability, and valuability assessment as well. And I think there's a lot of key things in here that economic considerations can fit into, as in the wealth of data you can get from the process evaluation that can help support economic evaluation, but also thinking about economic considerations really early on at the design and development stage can help feed into the feasibility and pilot stages. So for me, that was one of the kind of key missing gaps from the previous guidance. Some of the other things that were missing that had been suggested at the various workshops and such, a much broader remit that economics can offer, including and beyond design and evaluation, concepts and thinking about investment in population health, issues that we come across with complex interventions, particularly when we've got cross-sectorial outcomes. There, you know, who's going to be paying for it, who's receiving the benefits. They may cross, especially, for example, with education and health. Issues with the relevance of thresholds for decision making. So a lot of emphasis has always been put on in typical economic evaluation on the cost per quality outcome and a threshold around that, where quite often in complex and social care and health interventions, that is less relevant, and potential use for behavioural economics as well. So, yeah, there was also a lot of methodological updates that happened over the last 10, 15 years that weren't included in it. So, for example, guidelines and checklists on evaluations alongside natural experiments, much more advanced techniques now for modelling, and the various updated guidelines for economics in, for example, ISPOR, but also the guidelines from NICE with regards to social care and public health that hadn't been, that obviously hadn't been incorporated. Oops. Don't know why this isn't moving slides. Yeah, so Kathryn talked through this slide before, but I just wanted to highlight again, so the economics considerations in this most recent update is one of the key core elements, so feeds in to all 4 phases, but is also considered alongside the other 6 elements. So, for example, engagement and with stakeholders, identifying key uncertainties, a lot of the economic considerations fit in with that, so it's a lot more fluid than it was before. So now I'm going to talk through a bit about how the key economic things of importance within the 4 different phases. So starting with intervention, development and identification. Well, economic factors, what we've said in the guidance is that they should be embedded into programme theory. So there should be full incorporation into important decisions regarding development of the intervention. So in the early stages and in the mapping stages, what we quite often have is a lot of qualitative research being undertaken. So, for example, focus groups, interviews with stakeholders, just general discussions and workshops with stakeholders, with policy makers and government. And a lot of this information can be really, really helpful for the economists in helping think about what the actual decision problem is to them. So one of the key things is that the economists should actually be involved at this stage as well. Or if some of this early scoping stuff has been done before the economists got involved, what were the publications, what were the results of that? Economists can use that. And what we've advised in the guidelines is to build a conceptual model. So very basically similar to what the logic model is, build an economic conceptual model, basically using information from the stakeholders, from published literature, from all the engagement activity that went on to think about what are the key economic considerations, what are all the relevant perspectives, what are all the relevant factors that might be useful, and then we can progress that and say, well, what can we actually evaluate? And really important as well at this stage is getting the perspectives of relevance from the different stakeholders and decision makers, because that can help you then decide what perspective the economic evaluation, if you are to undertake one, should take. Modelling and simulation can also be done at very early stages like this to identify, but also to address uncertainties. For example, if it was a change in policy, you could do some modelling and simulation to look at how that might change and how that might influence things. But the key economic things to consider at this early stages, well, first of all, what, if any, is the existing economic evidence? Is there even any evidence on costs or any other economic evidence? What are the appropriate economic questions? Thinking about the systems and the programme theory and the economic conceptual model can help you think about that. What is important and relevant? And what perspectives are and is appropriate? And it may well be that there's more than one perspective. as some of the questions we're talking to Kathryn about choice. So it may well be that the economics needs to think about not just the NHS perspective or not just the patient perspective, but it might need to take multiple perspectives. And other questions as well, for example, should spillover impacts be included? Is there additional costs and additional benefits that wouldn't normally be incorporated? Are they relevant, and are they relevant to include? In terms of feasibility stage, again, identifying areas of uncertainty and early economic modelling can be undertaken. Again, the previous guidelines focused a lot on this, and the new guidelines still does. It is important. We may want to explore the likelihood that the intervention is going to be worthwhile. What are the potential costs and benefits? Do we think it's going to be cost effective before we go and fund something to test it? We can use the techniques that economists have, value of information and expected value of perfect parameter information, to address which areas are uncertain. So maybe we don't need a full-scale RCT, maybe we just need a smaller study, maybe we need a study to look at what the quality of life impacts are. And they can also help with decisions to progress to full-scale evaluation. But what's really important as well is the evaluability assessment, and the new guidance talks a lot more about this in terms of is it going to be acceptable and is it going to be feasible? And I think there's a big role for economic considerations in this, specifically in development and testing of data collection tools. And I'm not just talking about the outcome data collection tools, which it may well be, maybe it's not appropriate to collect CHU9D, or maybe we try to collect it and we can't get people to fill it in. But actually the resource use, especially in the social care context, and a lot of the public health and social care projects I've worked on, getting the resource use data collection from either the intervention or potentially the usual care arm can be really, really tricky. Whether that be that the systems aren't the same. It might be really difficult to extract the data. It might be really difficult to get, for example, social services and social workers to fill in data collection tools that we create. So basically developing appropriate data collection tools and testing them as to whether they're acceptable and feasible is hugely important. Identifying what other potential data sources there are, and refinement of the programme theory and the conceptual model, given all that. So this is a really, really key stage. And so economic considerations at feasibility isn't just about pre-trial modelling, it's about thinking about the kind of evaluability assessment. What can we test? Are we able to actually collect this data if we're to roll on into a full-scale trial? In terms of evaluation, there's many types of study designs that are out there. As Kathryn said, it's not just a big focus on RCTs anymore. We've got adaptive trials, we've got natural experiments, we've got observational studies, and economic evaluations can be done alongside these. So it's not as though we just have to do an evaluation alongside a randomised controlled trial. The guidance talks a lot about the importance of broader perspectives and also potentially taking multiple perspectives. And I would certainly say that I try to do this where it's appropriate in a social or public health context, rather than just taking the NHS perspective. You may need to take that, but you may actually also want to adopt a patient or a family perspective as well. And bearing that in mind, that leads on to the next bit about the different types of economic evaluation frameworks we have. When we were putting together the guidance and doing consultation with others, we thought, do we actually need to develop new methodologies? Does there need to be new frameworks developed? Or actually, can we just put more emphasis and utilise more readily the frameworks that we already have to hand? So traditionally, cost-consequence analysis has had a backseat of a role because it's not considered a full economic evaluation. Yet in the context of social care and public health interventions, it's a hugely helpful tool that can present a range of different outcomes to various different stakeholders as well. So it can capture these different perspectives. So it's a really underutilized tool, I feel, and tool that should be and probably is going to be used a lot more. And that can lead on to cost benefit analysis as well. So yeah, so the importance of these broader perspectives, importance of embracing that there are multiple and wider frameworks out there that we can use, and the importance of multiple outcomes beyond just health, so beyond just the quality adjusted life year, which health economists have always used. We've now got capabilities, we've got the ICE cap, but also, as I said, if you're using a cost consequence analysis approach, there may be other outcomes that can be captured within those frameworks. The guidance also talks about other frameworks such as social return on investment and multi-criteria decision analysis. Now, again, there was quite a lot of debate about whether these should be included or not. They are tools that are used a lot in business, a lot of policymakers like SROI, but they're not the standard tools that economists like to use due to weaknesses in handling outcomes. But they are more relevant and commonly used in complex interventions, so they are in the guidelines as signposted to alternative tools that can be used. And also there's signposting to the various different decision modelling techniques that can be used, going above and beyond, you know, the standard Markov modelling, but using micro simulation, discrete event simulations, agent-based and systems dynamics modelings. If you're taking a kind of systems-wide approach, these may be much more appropriate. And this slide was just to basically highlight some of the key methods and guidance updates that were referred to in the guidelines. So there was the social care guidance update in 2016, the public health guidance update in 2012, and then the 2017 update that kind of incorporated everything. And I've got a wee table to flick to that in a minute. And these guidance in themselves, they had already started to incorporate these broader perspectives. You know, so yeah, so as I said, also thinking about and introducing conceptual modelling frameworks that can be used, updated iceberg guidelines, and references towards behavioural economics and how some of these features can be embedded. This was just to highlight, this is a table from the NICE technology assessment methods guidance, and it's just to show, so on the various different elements of health technology assessment on the left hand side, comparators, perspective to take, types of outcomes to look at, and then the reference case is what's always really been used for standard evaluations. And so, as you can see, that would be RCTs, a cost utility analysis, and the outcomes would be EQ5D. But for public health and non-health interventions and for social care interventions, NICE had already incorporated into the guidelines a lot of these other wider perspectives, where societal or maybe employer perspective or patient perspective may be appropriate. And these frameworks were not just focused on cost utility analysis, so you may want to do cost benefit or cost consequence as well. Implementation is the final phase, and as we said, which I'd be interested to hear other people's thoughts on this as well, about how we can embed and how economic considerations can help with implementation. So implementation has not traditionally been part of economic evaluation, but what we've said in the guidelines is that it can and really it should be considered at early stages in the development of the programme theory and for reporting of the economic results. And I'll talk a bit more about that in my next slide. But you know, for example, if there's cost savings, if you're saying that this intervention is going to be cost saving, some people could assume that means that they're actually going to get money back, but there's actually going to be saving, but the cost saving may actually be in terms of freed up bed days. So it's just about making some of the results a lot clearer, but also thinking about implementation right at the design stage. Who's going to be implementing this? What if there's a huge investment going to be needed to implement it? We might find out it's cost effective, but the ICER or whatever your outcomes at the end of the evaluation may not help with actually if there's a large sunk cost needed for investment to roll out. So thinking about the economic considerations along with implementation right from the outset can be hugely helpful. Stakeholder and decision-maker engagement from the early phases can help with that. Thinking about the economic questions and how well and can results be used. So yeah, and the implementation issues can also be built into your economic conceptual model right at the outset as well. And it can help you preempt any implementation challenges that may arise. So yes, some of the what it can do, if you're thinking about economic considerations earlier on, it can help you preempt or avoid misconceptions with reporting or interpretation of the results. So I mentioned there about cost savings. It may actually not be a financial money they get back, but it might be freed up bed days, for example. It can help with interpretation of what the actual ISA is, which is very different to actually what the impact on your budget is going to be. So having a conversation about these things and what the outcomes are likely to be, and what that's going to mean for decision makers, and if decision makers are going to want to roll out, what will they need? Yeah, so yeah, there might also be issues with multi-sectorial evaluations. So it may be that the pairs don't reap the benefits, and there has been some methods papers recently on topics such as this, where decision makers can then think about things such as co-payment options. So, for example, why should the burden of payment always be on the NHS if the benefits received are in the education sector, or vice versa? So that may be appropriate. And also, cost of implementation assessments can also be undertaken. They can be undertaken post-evaluation. Should they be embedded into the research grant right at the outset or not? Yeah, and anything to kind of aid the adoption and roll out into practice if it was found to be worthwhile. So in terms of using the framework in practice, the key kind of messages in the guidance are early engagement with the economists in the project team, or get them onto the project team, consult with them as early as possible, so that you can have a much more embedded economic considerations into the important decision making, redesigning the intervention and the evaluation. And also that will really help with the appropriate perspective to be adopted for the economic evaluation, but also for what's relevant to stakeholders and decision makers. Building a conceptual model alongside the kind of logic model to help think about what the economic considerations are for the programme theory. That can help with shaping the design of the feasibility study, and it can also help with basically understanding the context within which the intervention is delivered. Broader societal perspective is much more likely. So, as I've mentioned before, using cost consequence and cost benefit analysis is much more appropriate than CE or CUA, or as in some of my recent projects where you end up having to do everything. So you do a cost effectiveness, so you're ticking the box for the cost, you know, the natural outcome, and then you're doing the cost utility analysis so that you're trying to get a handle on the cost per quality, but also doing a cost consequence analysis, so you're touching on a lot of other outcomes that may be relevant to different decision makers and stakeholders. And also considering the equity efficiency trade-offs. So there's this is talked about a lot more in the guidance. How often this is actually done is less prescriptive, but it is talked there, and should there be explicit incorporation of equity into the considerations. Oops. So I wanted to give an example of a recent NIHR funded study, which is currently still ongoing. It's called the Relationship in Good Hands trial, and myself and colleagues at the University of Glasgow are working on this. And it's a study looking at the clinical and cost effectiveness of a therapy called dyadic developmental psychotherapy. This is a therapy for abused and neglected children who have in the foster care system, and they have maltreatment associated problems. And the intervention is actually delivered not just to the child, but to the child and the parent. I don't know why this isn't moving on. Yeah. So it's a therapy that is we're considering in comparison to services as usual, which can be variable around the country. So variable around the country, but also variable within each site as well. And we're looking at basically, does the DDP therapy improve the mental health of 5 to 12-year-old foster children? And the economic question is it worth the commitment that families need to give it, the extra cost to the services to deliver it? So what's complex about this is it's an intervention that's for both the foster parents or adopted parents and the child, but it's also delivered in 3 different contrasting service contexts. So DDP can be delivered in the NHS, it can be delivered through social care, and there's also private practices that deliver it. So we're testing these 3. Services as usual can differ by site. So it's generally the child and adolescent mental health services, but in some sites it might just be whatever the social services offer. And so it can differ within each site as well as across sites. And so the outcomes are for the parents, the foster carers, and for the children. And it's a 3-phase, and so the NIHR have funded. So when some people are asking, will funders invest in larger scale, broader perspectives, broader scope projects? I think in some instances, yes, they have, and they already have started to do this. This is an expensive trial, a long-term trial, and they funded 3 phases: the mapping, the initial service, the feasibility trial, and potentially we'll move on to a full-scale trial. And the economics has been embedded throughout. Yep, so we finished the first stage. We are just coming to the end of the feasibility stage, and we're going to be moving into the full-scale trial. And I thought it was interesting to tell you like a little bit about some of the things from the feasibility stage. So we did the mapping stage, which was qualitative interviews. So there was a lot of scoping and engagement with stakeholders and how it could work and what the systems were, what did they collect, what did they actually do for services as usual arm. And so a lot of the qualitative stuff fed into the economic conceptual modelling. And we spent a lot of the time here as well just thinking about and designing the data collection tools, particularly the resource use tools. So we actually had to try and get a handle on what is the intervention in the 3 different service contexts, how it's delivered, how we can gather the information on who's doing what to when and how often. And likewise in the service as usual arm, which has been particularly tricky. So we spent a lot of time designing tools that would be considered to be appropriate to collect that data. The feasibility study, from the economics perspective, we didn't do a pre-trial model. What we've spent the feasibility time doing is exploring the resource use and outcome data collection tools. Are they actually being filled in? Are they acceptable and feasible to the 3 different study sites, and are they acceptable and feasible to the social services service as usual arm? And then a preliminary blinded analysis of resource use and outcome data. And so if successful, we'll move on to the phase 3, which is a cost effectiveness analysis within trial and a multi-sectorial lifetime analysis as well. So we're basically doing everything in their dog. We're collecting SDQ, which is a strengths and difficulties questionnaire, which looks at kind of mental health and capabilities of children. But we're also measuring the QALY via the CHU9D. We're also measuring incremental cost per QALY for the parents. So we've got the EQ5D for the parents to see, and the ICECAP actually as well, to measure capabilities to see, you know, is this helping parents? Is this proving their ability to function and be able to do things when their children are getting the support and they're getting the support? And we're also doing a lifetime multi-sectorial analysis and lots of different sensitivity analyses looking at the different outcomes questionnaires. Yeah, so that was just to give you a flavour of a recent study that's ongoing at the moment. So to summarise the implications for HTA of complex interventions, new methods, the guidance is basically saying new methods are not necessarily needed. What we can do is we can utilise existing methods and make better use of the existing frameworks. Can consider a wider spectrum of study designs, so move beyond the RCT framework and think about evaluations alongside observational studies and modelling using multiple data sources and types. We like to highlight the importance of a broader range of outcomes beyond health, so looking at capabilities, but also a whole wide range of outcomes that might be relevant to different stakeholders. And the cost consequence analysis can be really useful to show the cost multiple outcome trade-off rather than focusing just on evidencing effectiveness. And again, a shift away from focusing on ICER threshold decision making and focus more on cost outcome trade-offs that can be really well shown with cost consequence analysis. Equity efficiency trade-offs, and then implementation. And this is a question mark I've put here at the bottom of these two. Should these be considered included in the HTA procedures, or should they be just added in as an if when researchers decide it's important, or should these be mandated to be embedded? So yeah, so thank you very much. Any questions? I've got a bit for the next group discussion, but any questions so far?
Thanks enormously, Kathleen. So let's please either put your hand up. I can't actually, Angie, can you go to gallery or something? Or at least I can put your hand up electronically if you want to make a comment or ask a question. I'm looking in the participant list. Let me just go with something. First of all, I mean, firstly, Kathleen, thanks enormous. You packed a lot in there, which was great. No, that's good, in a good way. I mean, and music to my ears, I have to say, lots of things there. I mean, the implementation bit you finished with, I think this is clearly something which has really come up very rapidly in evaluation work in the last few years. People realizing that we've been, you know, as a research community, being very naive. This is not just social care, this is generally very, very naive about implementation work. What's the disadvantage of including implementation within the evaluation study design, if you like, at the beginning? Because you said you weren't sure whether it should be in or not. Why not put it in?
I think maybe just time and money and effort to do it. If we're not mandated to do it, why haven't people been doing it before? It's just not in our remit. I think it should be considered, but again, quite often economists we get approached right at the last minute, and even when people want to approach you earlier, they may not, and so your ability to think about these things and ability to get be involved in the engagement and stakeholder engagement part is therefore lost. And with the best will in the world, they may have discussed implementation, but some of the implementation things that the economists might think about or may not then have been discussed in that. And I mean, and this isn't just for social care and public health. I think in complex, clinical interventions as well, quite often they might prove that they're cost effective, but then they're not rolled out as well for various different reasons. So I do think that they should be included. I think I was just trying to think, why haven't they? Why is it taking so long for us to do this? And I think it's because if it's not mandated by, if it's not expected by the funders, we're not going to do it. And then by doing it, we might need to cost more time. And traditionally, funders potentially less willing to fund the economist's time right at the beginning when they're saying, well, what are you really doing? Are you just farting about? Are you actually developing a conceptual model? What is the deliverable from the economics if you're doing something at this early stage? So I do think it should be incorporated, and I think, but it just needs to be clearly set out what it is that you're doing and such. I'm rambling now.
Well, okay, you're rambling productively. That's okay, though. But I think I'm just going to say one quick thing, and I hand over to Adelina for a question. Which I think I wrote down in my notes as well. I think the sort of general thrust of what Kathryn and Kathleen, what you've both been saying is, we need to do much more work early on in the evaluation. It's thinking through those things. It's all those things that you both set out in planning the evaluation, planning what the implementation, what the intervention is going to look like, thinking about the context and so on. And I think it just changes the balance. Whereas, historically, you would see evaluations happening, and then researchers at the end spend ages and ages trying to work out why they got the results they did and to set them in context and interpretation and so on. And I think what you're saying is shift a lot of that earlier, because that will then make it much easier to get a good evaluation and to understand what you're generating from it. So I think that's a really important message, a general message. Let me go to Adelina. Oh, sorry, Kath. Sorry.
No, I was just agreeing with what you've said there. Absolutely.
Okay, Adelina, over to you.
Yeah, just what it says in the box. I just wondered if you could give some examples of the use of conceptual modeling in the early phase of developing the interventions, and if you had any ideas of examples that would be useful to look at, if you could suggest some references. Thank you.
Yes, I will do. Now, you've actually made me think, have we put any, I don't think we've put a conceptual model. I know there's logic models. I don't know if there's conceptual model reference in the guidance. So yes, I'll dig out some for you. I'm just trying to think. Probably the best way to describe, although we've not published it yet, is the one from the DDP study that I talked about. We developed a conceptual model for that one, basically feeding in all the different perspectives from the stakeholders and what was relevant and helping to kind of frame the question, and then thinking about all the things that we could evaluate and what was the economic question, and then basically cutting out the things that we weren't going to be able to assess and focusing on what we could, which we've actually included a lot, as you say, CHU9D, EQ5D, Y, ICE-CAP, EQ5D for the adults, but we all the things that we wanted to ideally capture, and then what we actually could capture. And one of the most difficult things is actually the resource use in the service as usual arm, but that's because of this is set in the social care context and setting, and the database systems aren't the same. And so a lot of the early work we spent doing that, and the conceptual model helped us to think about it, basically just putting it all down visually. What was there, what was important, what could we potentially capture, what couldn't we capture, and helping us think about what perspectives. So we've not published that yet, but we will. But what I can do is dig out some published conceptual models and pass them on so they can be added on to the links for this group, if that's helpful.
Yeah, thank you.
That would be wonderful. Okay, so I've got a comment from Juliet. Do you want to come in, just quickly comment, then we'll go to the general discussion. So Juliet, over to you.
Yeah, it was just a comment about what we were talking about the implementation costs. I think that they come to the fore if you kind of shift the question, and if you're more interested in thinking about continuing the innovation or intervention or spreading it elsewhere, then costs around implementation become really important, because they're absolutely critical to getting it up and running elsewhere. So, you know, when you talked about that systems perspective, it would seem to me that that systems perspective is partly what raises some of these questions and makes them seem more critical. So maybe it's also about taking systems perspective in the economics and having that consistency between the kind of economic evaluation and the other side of the evaluation. But yeah, just a comment.
Yeah, and a follow up to that, which I mean, nearly everything we do in social care research that I'm familiar with is trying to have that relevance and spread more generally. So, you know, just in the way that involvement became a necessary, very necessary and important part of research 25 years ago, and economics became a very important part of evaluation similar time. Maybe implementation science needs to be a key part of evaluation, sort of written through every evaluation study. I don't know. But Kathleen, I think you had another slide with some. I
did, yeah.
Stuff,
so now I didn't actually pose this when we were asked, I think, to have a general group discussion afterwards. So I don't know if people want to have a think about this. What next for developing capacity for evaluating complex interventions in social care? So just be interested in anyone's thoughts on this.
It's a nice, easy question. Thank you. So thoughts from anybody? If anybody want to come in with comments, put your electronic hand up or something into the chat is good. I mean, I'm just going to say something. I mean, in Kathryn's presentation, you put up from 2006 the kind of definition of complex intervention, or what would count as a complex intervention, and I think many people working in social care research would say that's everything we do, pretty much. You know, I think there's very few social care interventions which you could call simple, or if you did, you'd be simplifying so much they would lose their relevance to real world context. So I think everything that we do is different degrees of complexity, which is why I think, you know, what you've produced and what you've shown us today should be something which is, you know, is obligatory. It should be a sort of obligatory training course or reading material for everybody, because it is so rich in giving those suggestions, really.
I think, yeah, I agree. I think anything that involves human behaviour is not going to be a simple intervention. And because of that, we had quite a lot of discussions in developing the framework about whether we should even talk about complex interventions, because it's not necessarily the intervention itself that's complex, but the interaction with everything else going around about it. But it's such a kind of well-known term, and you know, there's a bit of a brand with the MRC guidance that we decided to keep it. And on training courses, we do actually have a reasonably new training course based around this framework, so a shameless plug for that. I can circulate details later to you. There will be a course online in November, and then another one in May, which is going to be in person, hopefully.
Shameless plug, but helpful. Thank you. That's good. Okay, Yvonne.
So, I mean, it's the biggest part of it, really, isn't it? But it's how we've managed to get practice to consistently collect data, and maybe the same data across the country across nations. And I know there are kind of core data sets, but they're quite limited, really. My experience of doing this is that, you know, when you try to come up with those sort of, well, exactly the tools to collect economic data, people just weren't able to capture it. They would say, oh, we don't have this, we don't know what this is, we don't do this. So there is a real fundamental challenge to doing this, and I don't know what the answer to that is. I don't know how we manage to persuade people how important this is.
Can I comment on that point? I agree with you, but in some of my examples from some of the social care projects I've worked on, they have the data, they have it there. It's just embedded in case report files, and extracting that for each person is just horrifically time consuming for either the social care worker, or for the research administrator, or for the researcher who you employ to do that. And then there's also issues of anonymity. So in social care, they want to do it themselves. They don't want the project researchers, even if they've been trained, and they don't want them to do it. So it's my experience within social care has been specifically really difficult to extract that data, and it has been that they do have it. It's just not in you know, an online package that can be extracted easily from. It's in case report forms, and it's quite often open text, and it's really difficult. And then to try and prospectively design something to get them to then fill out has been a headache as well, and that's on a couple of different studies. So that's been my perspective on that. I agree with your points.
Thank you. Right, I'm going to go in a minute. Go to Mike. We've got a deluge of Kathryns in the chat, which is good. So if Kathryn Robinson, Kathryn Needham, Kathryn Henderson, Juliet, anybody else wants putting things into the chat, if you want to raise questions or make those comments, it's sometimes easier for people to do that than read the chat. But first of all, let me go to Mike. Over to you.
Thank you, Martin, and thank you both for the wonderful presentations today, and thank you for your papers on this topic. I think they're wonderful invitations and also resources to engage more with complexity, and I think we do need to learn about that in social care research, more robust means of doing it. I think in terms of developing capacity, I think on the colleagues have already mentioned about capacity on the practice side, and I think there is need for more dialogue between the research communities and the practice communities about this complexity. I think often that's about developing resources, such as Yvonne said about data sets, but I think more generally, often practice will say what we do is complex, it's different here, that kind of approach wouldn't work here. But then they turn to researchers and say, give us the answer. We don't want to hear that it's complex. We don't want to hear that there's nuances and caveats around your findings. We want the answer. So somewhere in between those two stances that practice often makes, we need to find a better way of saying, yes, it is complex, and therefore there are these ways of trying to work through that together. In terms of developing capacity in the research community, I think we are growing, particularly through the projects of the School of Social Care Research, more expertise in lots of different methods and theories to approach complexity. I'm not sure that we've really committed to developing that capacity across social care research. I think we've got lots of individual researchers and some research teams that are growing, but I think we could perhaps do a little bit more to explore how we could support that group of people to grow as a community, and to start to explore some of the more theories in depth, or some of the more issues around complexity and context. So I think there's more that we can do to help nurture these approaches, and I think, as you say, Martin, perhaps building more expectations that complexity will be an important part of all or more research proposals would be an important signal there.
you. Did Kathleen or Kathleen do you want to respond to that? And I'm also just again invitation to people to put things in the chat if you want to turn them into questions, please do.
Thanks, Michael. I don't really have anything major to add to that other than I totally agree with everything that you said. And I think that you talking about our framework as an invitation for people to start thinking more about complexity is very eloquently put. And yeah, there are limitations to our framework, which we've kind of highlighted already, and there's work that needs to be done. And I think continuing this conversation and possibly, you know, having this fluid update of the guidance like someone else suggested is one way to do that. I think in terms of the multiple perspectives and having everyone kind of on the same page, evaluability assessment is a really good tool for doing that. If you're not familiar with evaluability assessment, it's possibly worth having a look at the methods that are used there. And more recently, in some of the work that we've done, I may have mentioned already, we've done quite a lot of kind of soft systems methodology. We've drawn on soft systems methodology within workshops to explore perspectives of various stakeholders, including those who are a kind of dissenting voice or might disagree with what you're saying. I think it's really important to draw on all relevant stakeholders, not just the ones that are going to be singing from the same song sheet.
Thank you. Okay, we've got time for a couple more questions. Anybody want to come in with things? If not, I'm going to a quick question for Kathleen then. I loved it when you said cost consequences analysis needs to be used more, because that's something that in social care I think works, is such an important consideration. I mean, I sometimes get frustrated when I get reviewer paper comments on papers that somebody's looking at economic evaluation through a very narrow cost utility lens. I mean, have you had pushback from people on your recommendations on the economic analysis? I mean, how has that been received?
To be honest, it's been received quite well with cost consequence analysis, which was one of the reasons why I was quite keen to put that in, and Emma and some of my other colleagues agreed with me, because I'd already had some of these grants and complex interventions in public health and social care, and what we basically did was say, well, we'll just do it. Oh, I said, really, I think actually cost consequence analysis is better, but actually they're still going to want this cost per quality, so why don't we just do, cost per I think cost per improvement in SDQ, which to me is kind of meaningless. And I spent a lot of time actually talking with clinical colleagues, well, what is a clinically significant improvement in SDQ? And there's a lot of debate about SDQ anyway, but they seem to be using it because it's quite a neat, easy tool to use, and then it's being used a lot. But is it the best tool to show child's improvement? I'm not massively convinced. So we said that we would do, cost per improvement in SDQ, and then we thought, well, let's do QALYs as well. So we've got and this is a different one. This is the best study, which is actually in the case study within the guidance. So we're doing a PEDS-QL, and we're mapping that to EQ5D because it's in a young child population, so we couldn't use CHU90. But we're actually doing a cost consequence analysis as well, because that actually captures much more, because it's a big complex intervention. There's lots of different stakeholders, there's lots of different people involved, and I just think cost consequence analysis fits with it. So, I mean, when we put in the application for that, so we did a phase 2 study separately funded. I was involved about 10 years ago. More than 10 years ago, it was 2009. So I was involved in some very early scoping stuff and some modelling stuff that I got one of my students to do with me, so that we did long before the big grant application. And then we built in, we did the feasibility stage, and then when we were putting in the full grant application to NIHR, we thought, well, actually, I just thought cost consequence analysis just speaks to it. So that's why we went with that, and that was long before this guidelines was updated. Yeah, I just think I agree with you. I just think it speaks better. But I think if you're just going to do cost consequence analysis on its own, you might upset a few people, and there will still probably be some people at either the funding board or when the final analyses come out, they're going to want something more substantial. So we just felt that we needed to do it all.
You. And I think just that also talks to the point made earlier that you've got many different audiences, different perspectives, different stakeholders in health and social care and public health research. And I think in social care that's particularly the case. And so having multiple domains of outcome is really important. Okay, Kathryn Henderson, last question. That's good timing.
Hi. Well, just picking up on my point in the chat was just that in terms of capacity, there doesn't seem to be all that much written about methods that qualitative methods for investigating economic considerations, in either health or social care, really. There's often discussions of focus groups, but there isn't much out there in terms of how you do these things and if there's specific ways to do them when the questions are about costs and service use. So just making that point.
Okay.
Can I just pipe in? I don't know if Martin wanted to answer that.
No.
I agree with you, Anna, but I think that qualitative methods economists can really use and feed into qualitative methods. So what I've done in the past and what we try to do along projects now, and this is why I'm talking about it can feed into the conceptual model at the beginning, but regardless of what stage it's at, if there's qualitative work ongoing, so for example, a qualitative survey amongst a subsample in your study, or qualitative, if it's focus groups or interviews, what we've done in the past is embed economic questions into it. Now, I don't know if this isn't following some standard methods, but what we've done is come up with the economic questions so that we can get the patient, so for example, the patient perspective, and the kind of the spillover costs. So example for families, or for partners, or for grandparents, for childcare costs, or for loss of leisure time, or whatever it may be in whatever context, embedded it in that way. And then unfortunately you then have a small subsample, say 300 out of your observational study, which has like 1,000 people in it, and you've got that for a small subsample, but we just get around that with modelling. So it's that feeds into an economic model and a secondary analysis on the patient perspective. But yeah, I think there should be more methods on how we should go about this. But yeah, that's how we've done it in various different projects and in various different ways. But I do think that there's a lot of really, really rich data in the qualitative findings, and actually having to go through qualitative transcripts is just horrific. So actually speaking with the qualitative people and reading their summaries and having a chat with them, you can actually embed, pick out some of the things. And when they're designing their qualitative work, if you work with them, you can embed your questions into it. So yeah, that's.
Thank you. And just we had a proposal came back from funding panel NIHR with a question: what sort of economic evaluation are you doing? And we've responded, it's a narrative cost effectiveness analysis. And they said, fine, that's okay. So I'm going to copyright the term, I think, but sometimes it is, you can be qualitative in this. It wasn't a very formal analysis. Anyway, listen, I'm going to finish now. Just thanks, Kathryn and Kathleen, fantastically rich presentations, so much stuff there, really, really helpful indeed. So thank you enormously for preparing that and giving that presentation. And to say to people, we'll have a recording of this, and I think the slides are available, but we'll have more material available on the SSCR website in due course, so people can come back to that. You've also got all the documents that were mentioned in the main report from 2021 to look at for the richness. So thank you very much for that. When you're starting to plug your courses more, tell us and we'll circulate the material around, so I'm sure there'll be lots of people interested in those. So thank you very much, and thanks to everybody who joined. We had over, I think it was 110 we got to at one point, of participants, people coming in and out. So that's great from our webinars. And then two more things to say before we finish. One is that we will have some more webinars coming along soon in the School of Social Care Research Programme. So keep a watch out for that. And this webinar was part of our general series, but also linked to our capacity building, and that gives me an opportunity to thank Yvonne Burks, who's stepping down as our capacity building lead in SSCR after 3 glorious years. So thanks enormously, Yvonne, for everything you've done. We're not going to let you go away too far, but thanks for your lead on the capacity building. And Kathryn Robinson, I'm delighted to say, is taking over that role from now. So more from everybody, from us soon. So thanks again, everybody, for joining, and thanks especially Kathryn and Kathleen. So Bye,
Thanks.
everybody.
Thanks for having us.
Thanks, everyone. Bye.
Bye.